The second case is a proximal tibial artery occlusion in a patient who we also use this device on. This is a very different patient mix altogether. She's presented with acute left foot pain, atrial fibrillation, who is rate controlled on flecainide and metoprolol, but not on anticoagulation. Coronary artery disease, it's a high list of comorbid conditions. She's a non-smoker and no contributory family history. She had sudden onset left pain radiating to the left knee, less than 24 hours after she was walking in the grocery store, debilitating. She tried to medicate herself at home and unfortunately was unsuccessful, and so presented to the emergency department where, if your system is anything like our system, they get a CT scan immediately upon entry into the door. So she got a CT angiogram, and I think what's evident is her left proximal tibial artery is devoid of flow. So once again, we took her to the arteriogram suite, performed a diagnostic agram. I think you can appreciate on the very far right of the screen there, she has a proximal tibial artery occlusion there, and so our therapeutic plan was to perform Pounce thrombectomy. Here's a little bit more magged up view of the lesion there. So it was a complex crossing profile with trailing thrombus into the TP trunk. We suspected, obviously, with her history of atrial fibrillation, that she had cardiogenic embolus, and so we placed the wire into the perineal artery. We did one pass that showed on the table revascularization into the foot, and there was high resistance flow concerning for either distal embolism, which I think is some of the common questions about in and about around the Pounce catheter, or spasm. So we actually performed dedicated tibial artery angiography, high quality tibial artery angiography, to prove that it wasn't distal embolization. There was no distal emboli that we found. And we added a little bit of intraarterial nitroglycerin. So that's before, and there's your after picture. So I think, as Denzel Washington would say, I think mission accomplished and good outcome. The last patient, this one took 62 minutes, so slightly longer, started on Eliquis, and the patient was discharged home the next day with a normal ABI.